right, thank you for staying with Daybreak. Let's start that conversation first on state of healthcare, but for now, let's take a look at the dailies first and then get into that conversation at the top of the hour. Dr. Davji Atela is joining us online. He's the CEO and Secretary General KMPDU. He's joining us from Mombasa. And Dr. James Nyikal, member of Health Committee and also member of Parliament for SEME, is with us here in studio. And Dr. Nyikal, I'll start with you on this one. We've seen the recent gloves off chit-chat between the president and the deputy president when it comes to politics. What do you make of that entire fiasco where the leaders are now just going bare knuckle?
Well, I think that is the expected end of what started a long time ago between the president and his deputy. Yeah. Way back, it was clear that things were not running well. Definitely after the handshake, it became clear, I think the president held back probably as expected of an elder and head of government and the state. Really is the head of the country, so I think he held back a bit. And his deputy went bare knuckle a long time ago. Yeah. Now, when it's come to this end, it's coming to his term, it is unfair to expect the president not to be concerned how things will be after he has left. So he will definitely make political decisions, which he will state. And I think the deputy president has also not been kind on his boss. Even if he's leaving, he's been very hard on him. And it's natural that the president can now come out hard and say it as it is or as he sees it. Yeah. I'm not surprised at all that that is coming.
Two things the deputy president said. One, he said that Jubilee, if it wasn't for him, Jubilee itself would not have been there. Do you agree?
Well, I don't agree that because even when they came together, the president actually had a higher chance in the original party. Yeah. The deputy president came with a smaller party. I think it was URP, and they had one of the president. But I think that even at that time, the president was a bigger partner than the deputy. So I don't think he's saying it would not have been there. But let's make it simply. Suppose he made the proposal that they form Jubilee and the president refused. Would Jubilee have existed? So that's a relatively presumptuous and a little bit arrogant statement to make. Yeah, I wouldn't have said it. Okay. I would have just said I made a serious contribution into Jubilee. Yeah. But now it has come to this, we are parting. I think sometimes you have to part with honor. Okay. And not with vitriol. Okay. Yes. And he also said that the president is looking for a puppet, and he was referring to Raila Odinga. So he was saying that the president, the current president, wants a president he can control because he never supported him before. Well, I think that the country can tell for itself. We really can't say that if you are looking for a puppet, you are going to pick Raila Amolo Odinga. For years, from the time he started politics when we were still little kids, some of us were barely born, he has always stood on his own. And he has actually gone through a lot because he didn't want people to control him. He had a clear idea what he wanted in politics. Now he has a very clear idea what he wants for this country. And he has taken decisions that has actually cost him what would have been an easier political future. When he decided to take on the Mao issue, he said, I can lose my elections on this. Well, whether that's why he lost elections, another idea, but it was clear he can do that. When you post the first constitution, I think 2005, it was clear that if he went against his boss that time, President Kibaki, and lost, he would lose his job. And he still went ahead and headed the opposition to the constitution at that time, the first constitution. So if he was somebody that was easy to control, it would have been clear at that time. So what Ruto is saying, maybe very young people, school children, may actually believe that. But most Kenyans, I think, will laugh it off. I will definitely laugh it off.
Okay. Dr. Davji, what do you make of this public spat between the two principals in the country, the head of state and his deputy? Davji, unmute your microphone, please.
Okay, I'm just saying, you see, politics is a game of interests. So when the interest of the two political leaders is now divergent, then now they have to take different directions because they don't see their future together anymore. And that's why it's automatically they'll come back and address different and completely opposite dressings, which now will have different agendas. That's why I think now we can see the president having a different agendas and driving different issues regarding even the period that have been in office, and the same to the deputy president. Ideally, I believe the interests are now not aligned, and that's why we have the talks that are going on now.
So for you, you think do you think it's a two-horse race? Because that's another conversation that has come up several times. Are there many other options that people should look at?
I think so far I can think it's a two-horse race because of the way or the nature in which the two leaders have packed themselves and the response that is also coming out from the public. It's ideally either we're going to have the president as Raila Odinga or we're going to have president as Ruto, depending on how much they're going to invest in the politics between now and September.
Yeah.
And ideally, you'll realize that, for example, in the health sector, we had what you call a People's Health Manifesto, the half-year nation, which categorically looks at between the two leaders so far, based on the support that they have in the country, which direction are like the leaders are going to take for the same. Yeah. So as of now, I will really say that it is a two-horse race for this election.
Dr. Nyikal, is that a fair assessment? That's a two-horse race?
As things stand now,
yeah.
it's definitely a two-horse race as it is. Because if you watch at the way things are moving, obviously it will be the collisions. There is Azmi on one side and there's Uda on one side. And now Uda has now come in with Mudavadi, and has got itself a new name.
Kenya Kwanza.
Kenya Kwanza.
Yes.
So that now seems to be the main. And there is
One Kenya Alliance.
One Kenya Alliance.
Yeah.
But obviously when you look at it, One Kenya Alliance is relatively smaller in comparison to the two. Yeah. And in my mind, the term two-horse race does not mean there are no other horses. Yeah. In my view, it means there may be other horses, but the ones that actually leading the pack and that people are looking at are two. In that context, for me, it is basically a two-horse race at this time, and likely to be at the other time. Because again, when you look at Koa Kenya, if you look at One Kenya, well, let's look at Koa Kenya. You still get the impression that they would shift and join one of the two. So that again makes it two-horse race.
Okay. The EACC is looking for more powers to summon or even to stop people from running for elections. Is that where the solution lies? Because you can see a few cases also coming up. On the front page of the Daily Nation, they're saying Hague clouds hang over DP. The ICC wants to interview witnesses who testified against Ruto in his post-election violence case.
Well, it need, actually, if you're going to run a fair and a free election, it should actually be free of violence. It should be free of fear.
Yeah.
It should be free of intimidation.
Yeah.
So the EEC really is the best placed institution now to sort out that. But as we know now, it doesn't have powers that can actually make it act fast. Let's even leave alone even the issue of violence. Look at even voter bribery. That is something that you really need to get rid of, get it out of the way in the country as it is now. But who can take care of it? But even if they were to see it happening, what powers would they have to actually take somebody, prosecute them. Those who are giving and those who are taking.
Yeah.
So I think they do need more power so that in terms of election issues, if there is something going on that is untoward, then they can move in and take action and make it definitive, and so that people know that if you do this, this is going to happen to you.
Yeah.
And with politicians, the most important thing you can do is say you are barred from running, or because of this you will not run again, or you will be charged and taken to court. If you don't have the powers to do any of those things,
yeah, then
obviously you can't do much. And I agree with them that they should look for more power, and I think Parliament should come on. I think they were with Justice Legal Affairs Department, and I think we should look at ways of making them stronger than they are now.
Okay. Davji, as you wind up on this conversation on politics and then getting the UHC coverage there, do you have confidence in the IBC to conduct a credible poll?
Yeah, I think as it is now, it's, I think I have a confidence in them. And what now we need just to be done is to the review of the IBC team. That both the parties, the different candidates must have a say in the IBC that conduct election. They should both be, they should have talks. The last time that we have election in 2017, there was no involvement of the parties up to the point of election. But I think if there's frequent updates with the IBC, then there will be possibility of having a fair election.
Okay.
I wanted to do something on that thing of ESCC.
Yes.
Particularly on the part of accountability of leaders in the counties, the county government leaders. I think if the power is really strengthened, it would be a good thing, because we have many leaders in the counties that have gone strongly against Chapter 6 of the Constitution in a way, in either an action that they took or in action that they did not do, to the point that if the same will come to contest to be leaders, then I think the residents or to the people they represented in the previous, in the ending term, will actually be an unfair thing to them. So if ECC is able to bring people down and make them accountable for every actions, it will be a great thing.
Okay. Dr. Nyikal, IBC, are you confident
that
they will conduct a credible poll?
As of now, they are trying, and I often don't want to cut people off and say, I don't think that will do it. What I'll say is that they still have a lot to do. In terms of the preparations. If they prepare themselves, they get the timelines right as they put it out, abide by them, and strengthen the structures that they have for handling any fallouts. And like now, I think we've just started, we are on the issue of registration of voters. They will now have to compile that register properly, and then the figures are clear. You go to the voting station on the day and things run out, then they can do it. But unless they do that, and we don't know how much they are prepared now, even with the electoral materials, they can, but they still have a lot to do.
Okay. I want us to shift gears and now talk about the state of healthcare. Dr. Nyikal, I'll start with you on this one. It's been launched by the president to all the 47 counties now. What does it actually take to achieve universal health coverage?
Yeah, before that, let me just correct something that I said a little back. When I was, we were talking about one or two horse race.
Yes.
I referred to One Kenya Alliance at Sokoa. Well, maybe I think I should correct that. I meant One Kenya Alliance.
Yes.
Yeah, whoever picked it should correct that.
Okay.
Universal health cover for Kenya is something that is a must. And I must say that the efforts that are going on are commendable. What are the main components of a cover? The main ones are actually financing. How is healthcare financed? Well, if you get your finances right, then the next one is actually health human resource. The people work on that. Then if you get that one, then you have to get into infrastructure and the supplies. Now, if you get all that, it will work. The intentions as they are now are good. We can see the efforts to strengthen NHIF and strengthen it, restructure it, so that it is the biggest source of money that we have now that can actually carry the universal health coverage program. So I think that is going on. We are also seeing an effort in improving the health human resource. There are legislation that are coming, but I think that one is still a bit of challenge. The other one is improving the infrastructure and the management of all this. Definitely, there are challenges, but the ingredients are there. If we work hard enough as a country, I think it is something we can achieve. But as it is now, the efforts are good, they're in the right direction, but we haven't got there yet.
Okay. Davji, what would it take to achieve universal health coverage?
You know, universal health coverage principle is basically based on this health as a human right in the country. That means there is need to have an accessibility, affordability of health to all. But when you look at, for us to achieve this universal health coverage, then we must have actually good governance. And ideally, it's a very good principle that it's a presidential initiative. But then the implementers to ensure and to realize that we have the universal health coverage is back down into the county governments, which I will bet there's no good governance. So if we don't streamline the governance of healthcare to the point that the decision made at, let's say, the national level will able to go down to lower facilities, then realizing universal health coverage will be a dream. So that aspect of governance has been a problem. And when you look at those pilot counties, you realize the same thing. That as much as there can be it's a very good vision with good policies and good plans, if it goes down to the governance who will not put finances that are needed to that healthcare, then you won't realize it. So that should be the debate that I think will debunkle and bring out the real aspect, that we need enough financing, enough human resource, enough infrastructure that do not only give us the brick and mortar, but really offer the quality services that every Kenyan will want to get.
Okay. Dr. Nyikal, give me your assessment of the pilot. We did the pilot in Isiolo, Machakos, Kisumu, and Nyeri. What went wrong and what went right?
The pilot, actually, when they started the 4 pilot areas, basically what they did was support those areas so that those who registered would get the services. So they gave the support to the facilities, they made the consumables available, and I think finances were available, and then people registered. The reports that have come out, what has been obvious is that it increased consumption, which means people needed the services that were there.
Yeah.
Concurrently, there was also registration of NHIF.
Yeah.
But what happened in places, I would say, for example, I'm sure in Kisumu, people then, when they registered for these pilots, then they didn't register for NHIF. So what has happened in some areas is that when now the pilot stopped, they found that their NHIF registration had gone down. But I think some areas actually continued at the same time. So what has come out, it has indicated there's a need for people to get this, and people need the service, and they showed that it can work. But it also showed that it is very important how people are registered into a system that will give them a universal coverage. It also showed that the funding can be targeted to health, but I think it came out a little more expensive than one would have liked, or than one would then carry into the full program of UHC. Yeah. So I think there are lessons we learned there. It also showed the importance, in fact, that is probably the most important. It also showed the importance of health human resource, because it was dragged down a bit by the issues of industrial action by the health workers during that time, which is to a large extent is the management of transition from national system run nationally as one, and a system that is now devolved. But I know that has been realized, and they are working on it through the intergovernmental relations structures. Yeah. So it showed the need is there, it showed it can be done, but it showed sometimes it's very expensive, and it showed the structures that need to be in place, particularly human resource and also supplies.
Yeah. Is the solution on NHIF? Is that where all eyes should be?
It's not, as in Kenya now,
yes.
If we want to have a universal health cover or universal health coverage, as I said, one of the most important things, I can say the most important is financing. So there are two ways you can finance universal health coverage. Yeah. One, you can use tax money. It's tax-based. You collect enough money. You run health services. The government pays through the taxes. People walk out, and people walk in and walk out, and they don't pay anything. Yeah. They call it the Lord Beveridge system. That is what they have in UK. And I think that's what we had very early in this country, around and just before independence. Yeah. Or you can actually finance health through insurance, particularly social health insurance, where everybody, if possible, pays some insurance according to their means. Yeah. And then everybody gets health care according to their needs. So you bring in an element of solidarity. And that insurance money is normally a big pool. It is the one that most countries have used. So it is actually the one that we have chosen to use. If you have chosen to use insurance as a form of achieving universal health coverage, then the institution that we have now that has the capacity, despite what we think of its shortcomings, but as the structures that can be strengthened to achieve that is NHIF.
Okay. Davji, what do you think? What is the best way of financing healthcare? Should we go the insurance way, or should the government just take up the role of financing healthcare? Because there's also been concern from people that even though we are going the insurance way, there's no standardization of costs and payments. Davji, unmute your microphone.
My take on using the insurance model, or rather using the NHIF, is the part of the service provision. As much as we have many or majority of the Kenyans will be able to be contributing to NHIF, and then NHIF will be a pool to have the funds. What about the service provisions in the public hospitals, that basically, and in other facilities? Because basically, if you contribute, then it means you need to go to an hospital that then offers you the services as required. But you realize that it's opposite. If you go to many of the public hospitals in the counties, you will not be able to get the services as you need. And most of the time, you'll be forced to go to a private hospital to get the services. And that was basically based on one of the studies that was done last year, whereby over 80% want to get the services, but they go to the hospitals and they don't find the doctors because they've not been employed. They will go, and if they find the doctors, there'll be no drugs. So basically, when we are getting down into the insurance model, basically the NHIF, the government also need to invest more in healthcare. The annual budgets of healthcare of 6% need to increase to 15%, and to ensure that there is a robust service provision by not acting only on the infrastructure, but ensuring that there's enough human resource in every facility to offer the services when you go to the hospitals with the insurance.
Okay. Dr. Nyika, let's talk about this in three different ways. There's accessibility, there's affordability, and there's standardization. Mm-hmm. Let's start with accessibility. What is the best way to ensure that people have access to healthcare? What should we do? Should we have dispensaries in each and every sub-location? What happens?
When you talk of access, there are two issues in one. One is financial access. the health services may be there, but you cannot access them. You may be living next to a private hospital,
but you can't afford it.
Yeah, you can't afford it, so you don't go there. The other one is physical access.
Yeah.
Are the facilities there? Now, in terms of financial access, that is where insurance comes in, social health insurance in particular. So let's assume that we do that, then we now have finances to cover so that everybody can go in. We can go into more details about that. Physical access is also important. It's not just the physical facilities. First of all, we should make sure that across the country there are physical facilities which will be used to provide the services for which will be paid for by the insurance, so that across the country we must have the facilities. And now in this country we actually have levels of facility.
Yeah.
We have level 1, which is actually the community, probably the most important one, because that is where primary health care takes place. That is prevention of disease,
yeah,
promotion of health, and early detection of illness, and quick treatment, which is always cheap. So that is actually what will control the cost. But leaving that alone, what most people think about is level 2, where you go to small facilities that take good care of you. Level 3, where you can get some deliveries and so on, so a little more complex. To level 4, which is what used to be district hospitals, where you can get virtually almost all levels except very specialized care. This must be available across the country.
Yeah.
In physical terms. And in my view, if you're looking at in a successful system, we should not just be thinking of public hospitals. There should be public facilities. There should be public facilities. There should be private facilities and faith-based facilities.
Yeah.
And if the pair is one, that should make it possible for people to access all these. Maybe in private facilities, they may have co-insurance or co-payment, yeah, because the universal cover may not, as it is, the insurance may not pay for that. But those facilities must be there. If they are physically there, and international standards is really nobody should travel more than 5, in the rural areas in particular, more than 5 kilometers, yeah, to the nearest center. If we can get that available, and it is possible in this country, yeah, in the devolved system, physical facilities are actually there. And I think we can put more. The governors can put more. Yeah. And they've actually tried to do that. Now, what then comes next? It is physically there. Mm. Are there people, health workers, who will take care of you in a proper, with the skills that are needed, yeah, with the human approach that is needed for sick people? 3, are there the supplies that they need? And if you go higher up the levels, are there the equipment that they need? Yeah. So that is really something that we must work on. And over time, we have been working on that. You hear programs that support level 2 and level 3. You hear of programs that support level 4, and you hear of programs that bring in equipment like the mess. They have their problems, yeah, but it is an effort that is there. So we must make that available. Yeah. It is achievable, yeah, but we have a problem, as you said, of standardization. Yeah. Again, that is now with the national government, the Ministry of Health. Okay. There have to be standards. When we say level 3, yeah, it should not. We are not just talking about public facilities. Yes. Even in the private, there should be that equivalent. Faith-based should be equivalent. Okay. At that level 3, yeah, you should get the same services, okay, across.
We'll come to standardization in just a bit. Let's finish up with access first. Dr. Davji, what is the main issue when it comes to access in your own assessment? Because I know you've been in this industry for a while.
I think the main issue of the access so far within the hospitals will be the human resource aspect of it. I will say, as my colleague, Dr. Nicholas explained, that you realize that there is the infrastructure, that is the hospitals, the brick and mortar. The governors have actually done very well in that, in building and ensuring that there are hospitals everywhere. And we have them as level 1, 2, 3, and 4. But their levels up to even to the maximum, up to level 6, is not based only in terms of the size or the sophistication of the building, but ideally it should be based on the service that they're able to provide. And this is based on the human personnel, the human resource that the human resource that they have. Like, for example, a level 4 need to have around 60 doctors, around 100 nurses, clinical officers. But you'll see that in most of these particular hospitals, mostly the public hospitals, there will be levels as level 3 or level 4, but the number of the personnel in them will be, I would say, 10% or 15% of the numbers that they need to have to offer the services. And at this point, somebody or a patient will go to get services, but they will not. They will have to be referred to higher levels or to referred to a nearby private facility. And in that regard, that will not be the right access to healthcare. And as Dr. Nikala also explained, in this context of accessibility, we have the faith-based, we have the private sector, and also we have the public. But majority of the Kenyans will first of all go to the public sector to get services, whereby they will expect to have the disease that they have, get diagnosed, they get the drugs, and they get the services holistically. But many a times, they will end up, I think about 73% from the last statistic that was indicated, will end up going to visiting 3 or 4 facilities before they get the issue sorted. Basically, because of lack of the personnel that are required, or the hospitals are not well equipped to offer those particular services they need.
Okay.
So I think that, in a great extent, interferes with access to the healthcare.
Okay. Dr. Nikal, what is the problem with the human resource in terms of getting people to work? Because we see, from the health committee perspective, why is it so difficult to just hire doctors? We can see us getting doctors from Cuba, and yet we have many doctors here. Why has it been a problem to just hire doctors, enough doctors?
For all human resource, you see, you even have had programs where the government is involved, where we are organizing for health workers to go and be employed elsewhere. And at the same time, you hear that in our own facilities, not here, you know that in our own facilities, there's shortage of nurses. Now, it is the management. It's the management of health human resource. Now, in this country, the health human resource is probably the most complex human resource you can have, not only in this country, across the world. If you look at health workers, you will start with, there are nurses there, you have clinical officers there, you have doctors there, you have pharmacists there, you have radiographers there, you have physiotherapists there. All these are people who have specific trainings. They are managed they were managed before in a unitary system. Now we devolved. Now when we devolved, this management structure, some of them actually have not devolved as should have. Now let's just talk about the recruitment of doctors. That I can talk about that, for example. Yeah. They are trained, and when they have trained, you have interns. Now interns are assumed to be still in training, but they are working. Now that is actually under national government. That when they complete, now they should be employed in the facilities. Now then they are now going to, that is county government. And there is no good, smooth transfer. I think they are working on it now. That is not happening. But if we just leave that, let's go into their organization. All these cadres I've talked about, they are well organized. They have regulatory bodies, the bodies that regulate them, their training, their registration, their conduct, and so on. These are actually national. They have unions, which are actually national, and they have associations. So each cadre has those three. Those are still national in structure. But we have not recognized that when they are dealing with them. So it gives us a lot of issues. Now, if you look at the Public Service Commission and the County Public Service Commission, again, you don't have a smooth transition. We have not worked out a smooth transition. If you have nurses and they are employed in one county, are they employed on exactly the same terms, or they are different terms? Are they transferable? Their training, when they are working, people still get trained when they are at work, particularly health workers. Is it the same across? Are they being managed in the same way? Are they transferable from one place to the other? Because these are now individual employers. Yeah. So those are issues that has given us problems. Okay. The other one is just actually managing them and recognizing their needs. Yeah. Look at what COVID showed, that health workers actually needed protection. They started dying, and they needed the protective gear. These were not available. They needed insurance. They also have health needs. So when they are sick, how are they treated? Yeah. Now, those things have not been looked at. So to a large extent, in my view, the problem is the management of the health human resource. Now, we have tried at the health committee, but remember, the health committee deals to a large extent with the national health at national level. Yeah. There is a health committee in the Senate. Where we are is in the National Assembly. Again, we have tried to actually sometimes come together to see how we can do this. There is the intergovernmental relations structures that again should be brought in, and I think they have tried. Okay. So to a large extent, it is management. There may be also issue of finances. Can we employ all of them? And what are the salaries that we gave them? You gave the issue of the Cuban doctors. Yeah. Actually, I think if you worked out what they were being paid, is definitely much higher than what the local doctors. We were ready to get that, but that I think was a political decision. And let me say it was kind of a knee-jerk reaction, that if the doctors here don't want to work, we can get some from elsewhere. It has been tried before. Yeah. It has never worked. Management of the human health resource is problem number one. Okay.
Davji, where does the problem lie from the union perspective in terms of human resources? What is the problem?
I think the first thing is that as long as we are looking at healthcare as an expenditure rather than investment, then we'll continue having a lot of problem in terms of human resource. When you look down a few years before devolution, the doctors used to graduate every year and be absorbed to different facilities in the country. But after 2016, then when the governors came in and became more aggressive in terms of wanting to employ, then the reduction in employment increased almost 100-fold. To this point, I'll say every year we have about, in 2015 up to about 2019, almost 600 doctors were being churned from different universities and being licensed. But then in 2019 and up to 2020, the numbers has increased to almost 1,000. Yeah. So when you look at overall in the country, in the last 5 years, you have about almost 4,000 doctors that have graduated. But if you look at the numbers that have gone into employment in either public or private sector, you realize about less than 20% of that number have been employed in both private and public sector. So there's a big number of doctors and a big number of nurses, a big number of clinical officers that have graduated and are not really employed to offer services. But then when you go to the hospitals, you realize that there's no services because there are no healthcare workers in those facilities. And one reason that why this happens is because the implementers of healthcare in the counties, that is, I would say the MCAs, the governors, even the senators, and even the MPs, and even the executives, the CSS and the CECs, they are not consumers of the same healthcare that they're giving to the people. So most of the times they will go for PR actions and try to show that there's an existence of an hospital when there's anybody with a lab coat, and even if they're not doctors or they're not nurses or they're not clinical officers. So that's, I think, one of the failures that we've seen. So that is, I would say, a PR aspect, mostly in the counties. Number two, the county governments have been claiming or have been stating that the expenditure monthly expenditures for within the budgets goes up to 32% of their county budgets into the healthcare. And so with these, they have been unable to employ healthcare workers in many of the counties. And that's why one of the proposals that we had from the Afghan Nations, other People's Health Movement, with Amnesty, with all other CSOs, together with doctors' unions and other unions, was that if that is the case, then there's need to increase this budget to 50%, so that there could be services by employing healthcare workers to offer service in those facilities. Okay. And then the national one should be increased to 15% as per their budget declaration of 2001. Yeah. Also to ensure that there's actually employment of the workers, because you will not say that you want to have services where we do not have those particular workers in the hospitals. Okay. So that's been the biggest challenge and the biggest complaint from the county government. But the ideal solution to the issue would be to have a centralized management of human resource, that is, having health service commission, whereby the counties will just be asking this particular body that we need 50 doctors, we need 100 doctors, we need this number of clinical officers, we need this number of nurses, without considering the budgeting aspect of it, but with an aspect of ensuring that they're offering the services that they need to offer to the people. All right. I think that would be a better solution to the issue of human resource. All right. I have to take a quick break here on Daybreak. We're talking about the universal health coverage, and Dr. Umo Luga is now joining us. He's the Director of Health Services at NMS. Thank you for making time. When you come back, there's some questions that you're posing to him as well, and his views on the issue of universal health coverage. We're talking about it in three ways: access, affordability, and standardization. Now, we've talked about access. We'll talk about affordability and standards in just a bit. Right? Keep your views coming at Trevor Mbija at Citizen TV Kenya. Use the hashtag Daybreak. We're coming back with some of your feedback shortly.